Good morning. Today we're going to be talking about anemia, appropriately stated deviations in air transport. The types of anemia that we will be discussing include iron deficiency anemia, which is the most common form of anemia caused by shortfalls in storage of iron in the body, vitamin deficiency anemia, including folic acid, anemia of inflammation, aplastic anemia. Anemia is associated with bone marrow disease, hemolytic anemias, and sickle cell anemia. The objectives of this lecture include the opportunity to interpret cardiovascular assessment findings to arrive at an actual or potential nursing diagnosis, to compare and contrast diagnostic tests used in the assessment of cardiovascular functioning, to analyze the pathophysiological changes that occur in the transport of air, and list expected outcomes for actual and potential transport problems. In addition, we want to select nursing interventions based upon evidence-based practice, and that's what we should be looking at when we're doing our care plans, that prevent, maintain, restore, and rehabilitate patients with deviations. To differentiate between pharmacological agents used, including their actions and the nursing responsibilities associated with those medications. Use expected outcomes to evaluate the effectiveness of nursing interventions. With regard to the NCLEX, the test plan is covering areas of health promotion and health maintenance and physiological integrity. The hematological system consists of red blood cells, white blood cells, and platelets. When you're looking at red blood cells, the function of the red blood cell is a primary oxygen carrier, and it collects carbon dioxide through the use of hemoglobin. The white blood cells, or leukocytes, are cells of the immune system, and they defend against those infectious diseases. Platelets, or thrombocytes, are very small, irregularly shaped clear cell fragments, and they are derived from megakaryocytes. The blood itself in the body, it consists of 5 to 6 liters of erythrocytes, leukocytes, and thrombocytes. The red blood cell is disc-shaped, and it allows for the carrying of oxygen molecules. Hemoglobin is an iron-containing protein of red blood cells, and iron is stored as ferritin, needed for that red blood cell for production. Platelets have an essential role in clotting, and the bone marrow is the site of blood cell formation. Anemia, as a general rule, is the reduction in numbers of red cells, the quantity of hemoglobin, which is that protein responsible for transporting oxygen, and the volume of packed cells. It can be the result of primary hematological problems or secondary to a disease process. Thinking of a disease process such as diabetes or kidney disease, oftentimes erythropoietin can get destroyed. We'll discuss that later. It's usually more of a symptom, and the causes can include blood loss, hypovolemia, impaired production of red blood cells, and destruction of erythrocytes. In making a diagnosis, health history is vital. Health history and physical examinations, including a general survey, can help you determine what's going on with the patient. Their shortness of breath, their activity intolerance, their fatigue, their pallor, things you might look at. What is a normal H&H? Things you might want to remember. An adult male is between 14 to 18 grams per deciliter. An adult female is between 12 to 16 grams per deciliter. Men after middle age, 12 to 14 grams per deciliter, and women after middle age, again, is going down, 11.7 to 13.8 grams per deciliter. What's happening in an aging adult? You're talking about intrinsic factor changes. As a patient ages, they're going to be losing some of that intrinsic factor, which is essential for vitamin B12 absorption in the body. With anemia, clinical manifestations include signs and symptoms that are caused by a body's response to tissue hypoxia. Transport of oxygen is very, very appropriate when you're talking about the signs and symptoms of hypoxia, not being able to reach periphery, oxygen not being able to reach periphery, not being able to reach the cardiac muscle cells, Intensity depends upon the severity of the anemia. And signs and symptoms can include palpitations, which are those kind of funny flutter feelings you might get in your chest, shortness of breath, fatigue, pallor, and tachycardia. And for a while you're bleeding off of your stores or using your stores, you can be asymptomatic for a while, but it does eventually wear down the stores and you will become symptomatic. Classifications of anemia include hypoproliferative, meaning that the cells are there's not enough of them, and bleeding. Hypoproliferative and iron deficiency anemia is a result of decreased iron in the body, and including iron stores. B12 and either a lack of vitamin B12 or folate causes a type of anemia called megablastic anemia or pernicious anemia. And of course, renal disease and its influence on erythropoietin can also cause a decreased signaling response to produce red blood cells. Bleeding of the GI tract include excessive bleeding, and especially that of the GI tract, can be chronic and could be acute, where excessive amounts of blood is lost. Trauma, again, excessive amounts of blood. And because the genital urinary tract is so vasculated, it too can be subject to excess blood loss. Iron deficiency anemia is the most common form of anemia, and iron is just not available for hemoglobin synthesis. The erythrocytes appear pale and abnormal in shape, and if you look over to the picture on the right, you can see that paleness, the inability for it to accept a dye, and its irregular shaped quality. Iron deficiency anemia, of course, is related to inadequate iron intake. Sometimes there are adequate stores, but there is not adequate iron intake. There's malabsorption. Malabsorption anemia can either be microcytic or macrocytic, iron deficient or caused from vitamin B12 or cobalamin deficiencies. Iron deficiency anemia is often a manifestation of celiac disease. Iron deficiency could also result from blood loss, an increased metabolic need, and/or a combination of the above. Clinical manifestations also include fatigue, shortness of breath, and syncope, which are episodes of loss of consciousness at times, or dizziness or dizzy spells. Pica can be an unusual cravings for certain foods that don't really make too much sense. Brittle nails, sore tongue, split tongue at times. When you look over to the right on the top, you're going to see something called cheilosis, which is basically a fissure right by the lip line of the mouth. The reason why the lip line is so subject to alterations is due to a decrease in oxygen blood flow. The lip line is very well vasculated. When you deprive it of oxygen, tissues die. And when the tissues die, the skin can't hold itself together. So when doing a history and physical, what would you expect to see? What happens if you're doing that general survey and the patient's coming in and they have that fissure around their mouth? They're excessively licking their lips. They may have difficulty holding on to a conversation because they get short of breath. They may not be able to walk across the floor without breathing heavily. For laboratory results, you want to look at H&H. You want to look at the serum iron. You want to look at the serum ferritin, understanding there is a serum level and there's also a stored level. You want to look at the red blood cells and occult blood. Occult blood is actually a sampling of stool that would necessarily result in an indicator turning black or bluish as in response or in the presence of blood. Many of us have done occult blood samples, and you will probably be exposed to doing those in the hospital if and when we get back there. An endoscopy is a scope-like procedure that is usually into the intestinal tract or sometimes down the esophagus, where you're looking for active bleeds. Medical management of a patient with iron deficiency anemia include identification and treatment of the underlying cause. What's going on? Is there a GI bleed? The replacement of iron stores, which include a diet-rich foods, oral or parenteral iron, and it can take a longer period of time to replace those stores. So you never want a person to experience iron deficiency for long periods of time because the buildup is much more difficult. The H&H is faster to replace. Of course, red blood cells, you could always just replace them with a blood transfusion. Pharmacological management of iron deficiency anemia include ferrous sulfate, ferrous gluconate, and actually ferrous fumarate. And each one of those different types of sulfate, gluconate, and fumate necessarily vary in the amount of elemental iron that are contained in each one of the actual medication. It's oral. It's about 300 to 325 milligrams 4 times a day. It's best absorbed in an acidic environment. Avoid binding with food. In other words, try to take it on an empty stomach. Unfortunately, it causes stomach upset and it can cause constipation. And liquid iron may stain your teeth. Side effects, as I said, include constipation, nausea and vomiting, staining of the teeth, and a blackened stool. Drug interactions include antacids. I said to take it in an acidic environment. And tetracycline. It will impede the absorption of tetracycline when taken with iron. Tetracycline will impede the iron, and the iron will impede the tetracycline. Food decreases absorption by about 50%, and stool softeners do need to be given. Parenteral iron can be given in an IM injection via a Z-Track method. I've given you a hyperlinked Z-Track method video, so you can look at it and just see what I'm speaking about. The objective of doing a Z-Track is to keep the medication contained within the area of the muscle that it's being injected, so it's a slow absorption and it doesn't cause any irritation to the skin as it kind of, if it runs out through the insertion site of the needle. There's no more than 2 milligrams per injection site. 2 milliliters per injection site. IV dextran is an IV form of iron. Please, please, please make sure when you're administering the first dose, you're doing a test to see how the patient responds to it. And as the infusion is continuing, to look for signs and symptoms of anaphylaxis. Assess for nausea and vomiting, headache, chest pain, and rash. Of course, in the cases of anemia, iron deficient anemia, diet can play a very strong role. Red meats, whole grains, eggs, vegetables, and vitamin C enhances the absorption. Vitamin C can serve as your very acidic environment that you're looking for. Anemia related to blood loss. I'm thinking of trauma. I'm thinking of an exsanguination. I'm thinking of something very, very quick, a car accident in which you have hypovolemia. You have chronic anemia, which usually is through the GI tract. People have these persistent chronic bleeds in the GI tract, and sometimes women have excessive menses cycles. Surgery can cause a reduction in volume. Oftentimes during surgery, there's heavy blood loss. Initially, the body tries to compensate with vasoconstriction. Over time, the sympathetic nervous system loses its ability to maintain that vasoconstriction, and it vasodilates. At that point, the blood pressure will drop. Initially, during those compensation phases, vasoconstriction may keep the blood pressure up, keep it not high, but keep it up, not showing any signs of bleeding. But as the ability to compensate is lost, the sympathetic nervous system can't keep up anymore, and people will bottom out. Their blood pressure will drop. Also, the same type of situation in a trauma. Initially, blood pressure will be maintained, so it's deceiving. But as the blood is lost, the blood pressure will drop. Again, diagnosis of blood loss requires a very detailed history and physical, looking for ideas of, is heavy menses part of the problem? What's going on with pallor? What's going on with fatigue? What's going on with activity intolerance? And endoscopy also serves as a good piece of data for diagnostic purposes. And labs of the hematocrit and hemoglobin are also essential. Understanding that the hemoglobin is the protein contained in the red blood cells that is responsible for the delivery of oxygen, And the hematocrit is the measure of the volume of red blood cells compared to the total volume, the total blood volume. And the hematocrit is given in a percentage. When a person is losing blood, clinical manifestations vary according to the amount of blood loss. With 10% blood loss, there may not be any clinical manifestations. With 20, maybe the heart rate is elevated with 20%. I'm talking about maybe 120, 130, 140 on the heart rate. At 30%, the blood pressure may be holding. The pulse is okay at rest, but not when there's any activity. At 40%, again, we're talking about that sympathetic response is no longer there anymore. So the vasculature tends to vasodilate, causing blood pressure to drop, the weak, thready pulse. At 50%, there's shock and potential risk for death. Of course, when you're losing blood, it's imperative to know where the blood is coming from. Talk about the ABCs, airway, breathing, the circulation part of it. You don't want a hemorrhage for too long. Replace blood with packed red blood cells. Isotonic fluids, such as 0.9 normal saline and Ringer's lactate, are great for volume expanders. A blood transfusion could be done at the hospital. Would be done at the hospital. And they would be done if there is a lower hemoglobin, which is established by the hospital. Usually hemoglobin below 8, they will start a transfusion if that's how the patient comes in, or if they're actively bleeding. But please check with the hospital policy to determine which one it is, because it could be either or. So if a person is actively bleeding, they usually get the blood transfusion, and or if their hemoglobin is below 8, they will get it. Again, hospital policy. And of course, iron replacements will follow. B12 anemia is also known as cobalamin deficiency. B12 is needed for DNA synthesis and red blood cell production. The B12 is absorbed in the ileum. The problem of absorption is also due to the intrinsic factor, aka pernicious anemia. Intrinsic factor is produced by the parietal cells. Unfortunately, intrinsic factor diminishes with aging. So a lot of times the aging patient, you'll find that the H&H is lower due to the lack of intrinsic factor. And sometimes they can be chronically anemic and will be receiving B12 injections. Causes could be a gastrectomy, the removal of part of the stomach, a small bowel resection, poor nutrition, and I'm going to say it's a vegetarian who may not be skilled yet, or maybe a naive vegetarian who's learning the tricks of protein replacements and things, and B12 replacements, and medications that block the absorption of B12, which of course include phenobarbital, anti-seizure medications in general, tobramycin, including those or some of those antibiotics, potassium and potassium products, and medications that are used for histine blockers, things for the stomach and for the gut to reduce acids. Somebody with B12 anemia will, of course, have signs and symptoms that are consistent with anemia, and symptoms that are associated with tissue hypoxia. They will appear pale, short of breath, tachycardic. They will appear weak and listless. Sore tongue. It could be a smooth tongue. They'll have anorexia. One thing about B12 is because of its neurological implications. B12 is often given to patients who have dementia and Alzheimer's. Look for weakness, ataxia, paresthesia of the hands and feet, which is that tingling feeling, and an impaired thought process. Diagnosis is, of course, consistent with a history and physical labs, which include an H&H, cobalamin levels, and a Schilling's test. The Schilling's test is a 4-part test. It's pretty long. It takes a while to get those results, and it's in a 4-part series. I think it takes a few days, and that's why I don't see them too much in the hospital anymore. They might be done more on a home basis than in the hospital. Medical management, and consistent with that Schilling's test, is to identify the underlying cause of that B12 anemia. Look for the intrinsic factor, maybe the end product of a bowel resection. It might be nutritional issues, or it could be a combination of all those things. B12 is a coenzyme that affects cellular metabolism and works with B9, which is folate, to synthesize nucleic acids, to maintain a healthy nervous system, and to prevent the anemia. The B12 is absorbed in the gut, and it requires the intrinsic factor. No intrinsic factor, no absorption. Dose is up to 1,000 micrograms per day, and the PO route is preferred for nutritional deficiencies. Parenteral B12 is used for malabsorption cases, and the doses are necessarily posted there, 5 to 100 micrograms IM subQ daily for 6 to 7 days. It's not IV. This is not the IV form of this. There's also the intranasal. Intranasal could have its own specific types of side effects, which includes irritations of the nose, throat, airway. Side effects include diarrhea, hypokalemia, pain at the IM sites. Interactions include colchicine, anticonvulsants, and Tagamet, consistent with medications that are coating the stomach or stopping stomach acids. Alcohol and vitamin C can decrease the absorption in this case. B12 nutrition includes eggs, meat, and dairy. And questions would be always asked on nutrition: what types of food products, cottage cheese, and things like that would necessarily assist in B12 absorption. Folic acid is the synthetic form of folate, which is a naturally occurring vitamin B. It is necessary for red blood cell growth and cellular division. It is stored in the body as folate. Causes can include, or a folic acid deficiency could include poor nutrition, malabsorption, alcoholism, and drugs that interfere with absorption. Diagnosis includes a proper history and physical, looking at labs, of course, H&H, and folate levels. Folate levels you always see being done during nutritional evaluations, but will be done in the case of trying to find the cause of the anemia. Signs and symptoms would necessarily include anorexia, nausea, fatigue, a smooth, beefy tongue, pallor. Again, we're looking at very, very consistent anemic signs and symptoms. And you'll find that they are all consistent, but now it is deciphering the information to determine, getting that great data collection to determine which potential type of anemia it is. Folic acid deficiencies would necessarily be potentially nutritional in its nature. Folic acid is a PO replacement. You can do it in a flushing and a non-flushing version of it. Flushing just means that when it's taken, it causes massive flushing on the periphery of the system, like the fingertips, the toes, the face, ears, and can be a very, very uncomfortable feeling if you're not familiar with the way flushing folic acid makes you feel. 1 milligram per day by mouth. For malabsorption, it might be 5 milligrams per day, and of course it depends upon the cause of the folic acid deficiency. It is well absorbed, it crosses the placenta, and is highly protein bound, meaning that it will kind of break off when the coenzymes are added, or when it has enzymes available in the system. It'll break down over periods of time and be brought into the free form. The side effects of folic acid include that rash and fever. Sulfonamides are drug reactions. Sulfonamides decrease the absorption. People who have like ulcerative colitis, it's an antibiotic, and it will decrease its absorption. A lot of times folic acid and estrogen are given concomitantly for the relief of postmenopausal symptoms. So if you're taking estrogens, the requirement for folic acid may also increase. The onset is within 3 to 5 days, and it peaks within 5 to 10 days. Aside from supplementing folic acid, meats, green leafy vegetables, kidney, and lima beans are great nutritional sources. Anemia of inflammation, which is also called anemia of chronic disease, is a common normocystic, normochromatic, meaning that the size and the shape of the red blood cell stays the same, and is caused by underlying inflammatory diseases. It is diagnosed with serum iron concentrations are low, but the stores are adequate. It is also evidenced by serum ferritin, which is not low. So hematocrit is 25%. The hemoglobin is greater than 9 with few symptoms. It develops over 6 to 8 weeks, and treatment is based upon the underlying disorder. whatever the underlying disorder may be. If that is resolved, then of course that potential for anemia is also diminished. And of course, anemia of renal disease is hypoproliferative anemia resulting from deficient EPO, erythropoietin, or it's a diminished response to it. It shortens the red blood cells lifespan. The degree of anemia depends upon the severity of the disease. Again, always checking for people who do have kidney disorders, usually associated with folic acid and iron deficiency anemias. So thinking about the cycle of a proliferative disorder where there are decreased red blood cells, erythropoietin is usually that trigger mechanism that provides an increased production by the bone marrow of red blood cells. If it's not functioning correctly or it's diminished, it will cause anemia. Looking at labs, H&H are always important in red blood cell count, serum iron, folic acid, the BUN and creatinine, necessarily to check out the kidneys. Clinical manifestations include weakness and fatigue, but don't forget there's a potential underlying kidney issue, irritability, shortness of breath, and pallor changes. Medical management includes nutrients for the red blood cell production, administration of erythropoietin, which is a sub-Q injection at most of the time, oral iron folic acid supplements, and monitor H&H during the therapy. Erythropoietin is a glycoprotein necessary for red blood cell production. 50 to 100 units per kilogram is given 3 times a week. It is well absorbed. The protein binding is not really known, and its half-life is within 4 to 13 hours. Given subcutaneously, its onset is within 7 to 10 days. The side effects include hypertension, nausea, edema, rash, and diarrhea. Severe reactions can be seizures and hyperkalemia. Again, watch cardiac monitoring. Monitor response to symptoms, especially vital signs, blood pressure. Monitor labs, H&H, potassium, and iron levels, and monitor renal function. Aplastic anemia is an autoimmune disorder in which the body fails to produce red blood cells in sufficient numbers. So there's a decrease or damage to the stem cells within the bone marrow, which affects the red blood cells, the white blood cells, and the platelets. It can be congenital. It could be idiopathic, which they have no idea. Infections and pregnancy will worsen the situation, and potential toxins in the body and in the environment. Diagnosis is through a history and physical. Labs include looking for CBC, iron, platelets, coagulation exam. Again, bone marrow aspirate would be the best way to determine where the dysfunction is coming from. Clinical manifestations, again, super similar to all of the anemias: pallor, weakness, fatigue, shortness of breath. Infections, as the bone marrow is being affected, headache, malaise, neutropenia, and bleeding. Again, medical management includes identifying the causative agent to measure, to protect against infection, but continue with blood transfusions. The potential for immunosuppressive therapy would not be great at this time due to the coronavirus. Supportive therapy, oxygen and diet, bone marrow transplant may be necessary. Assessment includes early detection, a history and physical, symptom review, a review of meds, a family history, alcohol intake, nutritional assessment, cardiac status, a neurological exam, and a review of the GI system for potential bleeding. Nursing diagnoses, of course, are consistent with altered tissue perfusion, activity intolerance, and altered nutrition less than the body requirements. Assess using the skin. Look at capillary refill, look at pallor, look at temperature, monitor the labs, assess mental status, and monitor oxygen with your pulse ox. Capillary refill is less than 3 seconds would be a goal, making sure that they are alert and their labs are within normal limits. Interventions are to assess for weekly weight, to assess nutritional intake, to consult a dietitian. The outcomes include maintain an adequate nutrition, list the foods that enhance red blood cell production, demonstrate weight gain, and repeat. Alternate rest and activity levels to monitor the vital signs and monitor labs. Assess the ability to perform tasks. The outcomes are to be able to participate in ADLs, to have vital signs that are within normal limits. And this concludes the slide on anemia.